Okay, your renal's uploading and we're going to go on to women's health. Alright, women's health. This is from chapter 41. And like I said before, I'm not going to go over although I signed the breast chapter, I'm not going to actually have a PowerPoint for that. We're going to cover some tips, some specific information from it on breast, but you should look over it. As far as your test goes, as usual, it's usually basically if you study your PowerPoint. I've cut out a lot of information that I don't think you need out of the book because it's so there's so much material to be had. So if you're having trouble with exams and passing them, you need to uh, cut down what you're studying. Okay, first we're going to talk about disorders, the vulvovaginal disorders that women run across. Candidus is probably one of the most common infections that women usually run into. It's a fungal infection. We know it as a yeast infection. It's a white cheesy discharge. You have a lot of intense itching going on. It's hard to sit still when you have this disorder. One of the things that you want to uh, look for when you are suspecting a yeast infection might be the use of antibiotics, diabetic, um, taking douching, things that may upset the bacterial flora, natural flora in the vaginal area. We treat it with an antifungal, either orally, topically, or vaginally. We teach our patients to wear cotton underwear. This is actually transferable. Mom can transfer it from her vagina to her breast, and then from her breast to her infant that's breastfeeding, and vice versa. They can transfer it back and forth. So it is a transferable. And usually we treat babies usually with the thrush with the nystatin to make sure that we are doing what we should be doing to try to prevent cross contamination. Um, the vulvodynia is where you have the chronic pain either without stimulation, or you have chronic burning, soreness, um, rawness, stinging. It's very difficult to actually diagnose this particular disorder, but it does exist, and about the only thing that you can do is to treat the symptoms because they really don't know why that chronic pain is there. Bartholinitis is caused from the Bartholin cyst becoming inflamed. You have two of those, one on each side of the vaginal opening. The cause of the inflammation can be a blocked gland that's usually caused by streptococcal or staph. Sometimes it will even actually form abscesses, and you have a lot of pain with these cysts. Any type of cyst usually causes you to have a lot of pain. We're going to treat it with antibiotics, or if we have an abscess, we're going to have to go in and do an I&D on there. The cyst is still going to be there. It can become reinfected at any point in time. So we have to be sure that we are aware that once we get an infection there, we may be getting another infection there. So you want to be teaching your patients how to watch for that. Cystocele is between the wall of the bladder and the vaginal wall is going to weaken, and that bladder kind of protrudes not into the bladder actually, or not into the vagina, but it pushes onto that weak part of the wall, and the bladder bulges into the vaginal area. Usually it's called by multiple vaginal deliveries. You'll usually see maybe some urine leakage and feel some pelvic pressure and have some UTIs from that. A rectocele is simply where it's the rectum instead of the bladder pushing into the vaginal wall and into the vaginal vault. Usually You'll have trouble initiating a bowel movement because that little pouch is there, and stool will actually accumulate into the pouch and not actually at the rectum, so it's a little difficult to initiate a BM. You'll see some constipation going on with that, some rectal pressure. If you've done your Kegels throughout this program that I've been trying to teach y'all to do, you'll never have that problem. Surgical repair, the A&P repair, anterior and posterior repair, is one of the things that they do to fix rectocele and cystocele, and they can do them both at the same time. Although, if you've ever seen this done, you probably would never want it done because of the positions that they actually put your body in to do these particular repairs. You want to be sure to watch very closely for vaginal bleeding. Uterine prolapse is just exactly what it says it is. The uterus prolapses out into the vagina. This is an emergency situation if it occurs during childbirth because of all the hemorrhaging that can happen, and usually a hysterectomy is our only way to stop the bleeding. It's not an emergency situation. If somebody elderly has a prolapsed uterus, there's not any bleeding going on, they weren't having a baby, it just kind of plopped out of there because they had weak muscles. Could be due to obesity, chronic coughing, straining when they go to the bathroom. We can go in and do surgery to suture the uterus into place, or we can put in a pessary to actually push the uterus back up into place, and the pessary will hold it. It'll have to be removed and cleaned every day. Or we can do a hysterectomy and get rid of the whole problem. Sometimes it's difficult for patients to come to terms and accepting something like this, and usually when you know they're accepting it is when they find something good in the situation of, like, I'm so glad I had that hysterectomy because now I don't have to worry about my uterus being hanging out between my legs and causing me trouble to walk. Fistulas are those abnormal openings or tracts between two structures, usually between vaginal wall. May have a fistula in it. You can have a cyst fistula. You can have a rectal fistula. So these all will have to be actually fixed by surgery, and they do need to be fixed because you don't want fecal matter in the vaginal wall because it will go up into the urethra, which will go up into the bladder, which will go up into the ureters, which will go up into the kidneys, and then we have all kinds of problems. Our uterine and ovarian disorders. Uterine fibroids is one of our most common benign tumors that we have of the uterus. It grows very rapidly, especially in pregnancy, because of the estrogen supply in pregnancy. You'll usually see some bleeding, some pelvic pain. It may cause infertility if there's quite a few of the fibroids. It may cause a pregnancy loss. Usually conservative treatment is going to be NSAIDs, birth control hormones, or a hysterectomy. So if they have to have a hysterectomy, you want to be sure and do a routine vital signs and monitor your patient for how she feels and do some therapeutic communication, because depending on the age as to how this is going to work with them. We have actually tried to vaginally deliver a patient whose fibroid was very small when she got pregnant, and by the time she got ready to deliver, the fibroid was as big as the baby, so we actually had to do a C-section on her because she just couldn't get a good rhythm with her contractions. Pelvic pain, a lot of women have pelvic pain. If it's cyclic, it's usually middle schmerz or painful cramps with your cycle. If it's non-cyclic, then it's really related to pelvic inflammatory disease. And pelvic inflammatory disease is discussed in our sexually transmitted diseases, so we will talk about that there. Endometriosis is when your endometrial-like cells are actually found in areas outside the uterus. They grow and slough off just like with every menstrual cycle, just like the cells do inside the uterus. causes you to have your period every month. It causes a lot of inflammation and pain. It causes infertility. There's a lot of dysmenorrhea with this, a lot of abdominal pain and back pain, a lot of fatigue. The treatment for endometriosis, they usually will try oral contraceptives and NSAIDs. If you happen to become pregnant with endometriosis, your pregnancy will actually pretty much get rid of all the endometriosis, but once the baby's delivered, the endometriosis will come back. They have not figured out how to keep it from advancing like it should, but they can keep it somewhat in control with oral contraceptives and NSAIDs. Then we have the ovarian cyst, and anybody that's had one knows how painful they are. There's different types of them. There's follicular ones, there's the corpus luteum ones, and then there's the dermoid cyst. The dermoid cyst is actually a germ cell tumor, and it may have teeth and hair in it, but it is not from a product of conception. The corpus luteum is a lot more painful than the follicular one. It can rupture and cause hemorrhage, and it is caused by a decrease of the luteinizing hormone. And the follicular ones usually just cause bloating and tender breasts, and they don't rupture. Now, of course, ectopic pregnancy, we've discussed ectopic pregnancy in OB. So the thing you want to remember about ectopic pregnancy is anybody that comes in of childbearing age into the ER complaining of abdominal pain, especially if it's on the right side or the left side, are very much suspected to be having a ectopic pregnancy, which is an emergency situation. So you will need to have them seen immediately. You can give methotrexate and dissolve this pregnancy if it's not very far along, or you may have to go in and actually remove the tube, which is a bad thing. Sexual disorders. Yeah, I know I'm hesitating. I can't help myself. It's just kind of, you don't see a whole lot of information on orgasmic dysfunctions with women. And if you'll notice, the paragraph in your book is very short. There's a lot of things for men and their sexual disorders, but there's not a whole lot of things about orgasms in this. It's, one of this anorgasmia is one of the most common sexual problems in women. But less than 20% of it's known as a physiological issue. They usually think it's a psychological in nature, so they're actually saying it's all in our head, and it's usually from unresolved conflicts from about sexual activities or marital conflict. So it's really kind of, as far as I'm concerned, something that they don't do enough treatment with. They say you may be able to improve it with Kegel exercise and masturbation. So you may also need to be treated with some counseling and some psychiatric medications. Dyspareunia, of course, is painful intercourse, and it can be physiological or psychological with females. And usually, if we have some hormonal treatment, it can help replace some of that tissue in there. So basically, with our painful, we have to figure out what the cause is, and then we'll treat the cause. And menopause, your cause is going to be dry vaginal skin, and we usually treat that with estrogen, and that usually helps have less painful sex. And then we have all kinds of menstrual disorders, and probably every single one of us that have ever had a menstrual cycle knows exactly what all these are. Amenorrhea is when you've never had a period at all. Primary amenorrhea is when you've not had a period and you should have had a period because you have secondary sexual characteristics that indicate you should have had your period, but you don't. Secondary amenorrhea is when you've had your period for a year or two and then all of a sudden you don't have your period. That's called secondary amenorrhea. The secondary amenorrhea can be due to anything beyond being pregnant, such as extreme physical activity, extreme weight loss, possibility of weight gain. All those things can cause primary or secondary amenorrhea. Oligomenorrhea is just when you're having a very light, small period each month instead of a heavy one. And most of us go, yeehaw, I'm so glad that I didn't have. Polycystic ovary disease is a very common endocrine disorder, usually affecting our childbearing age. Polycystic ovaries don't have to be present for the syndrome to be diagnosed. We don't know what causes it. Scientists think that there may be some genetic mutations that cause this. Usually what we treat this with is metformin. Metformin usually helps in decreasing the polycystic ovary syndrome. We can also cause this to happen when we are trying to get pregnant and we take Clomid to get pregnant, and it can cause stimulate our ovaries to overproduce, and so then we go into they will start making cysts instead of eggs. So we usually can have that going on. Some of the symptoms that we may see that we're having, we may grow some hair on our face, may have some acne, infertility, pelvic pain, infertility, and of course obesity is one of your big things. So we really need to try to manage to give that metformin to try to help them decrease their polycystic ovaries. Dysmenorrhea is painful menstrual cycle. Basically, 50% of your women are going to have dysmenorrhea. And then, of course, sometimes there is a secondary dysmenorrhea, which is caused by your endometriosis. With the primary dysmenorrhea, there's an increase in uterine muscle contraction. So that's usually caused by the prostaglandin levels. Some of our medical things that we want to do with these, we try to treat the pain, but your book tells you not to use NSAIDs if you have patients with hemophilia, bleeding ulcers. But usually NSAIDs are what's been used more than any other drug in trying to treat anything with bleeding or pain in women's health. So you want to be sure to tell them to maintain a good diet, exercise, take fluids, use heat, and NSAIDs in moderation. They don't offer a cure for it. There have been times where they have actually recommended antidepressants to help with dysmenorrhea. Menorrhagia is excessive or prolonged menstruation that, it's usually varies from month to month. Treatment depends on the cause. Sometimes it's a method of contraceptive, such as an IUD, might cause them to have some issues with bleeding more than they should, or von Willebrand factor can cause excessive bleeding. Your cervical polyps are benign growths that are on this endocervical canal, and we don't know why they're there. We just know that we have a yellowish discharge and abnormal vaginal bleeding from them. Usually occurs during intercourse or between periods. And usually we just remove the polyps, usually in an outpatient setting in your doctor's office. Menorrhagia is the irregular, frequent menstruation periods that we see. We don't know what causes it. We just know it's dysfunctional bleeding. We do the same thing for it as we do with endometriosis and STIs. We try to remove whatever the problem is that's causing it and try to go on with it. Now, PMS is a big thing. PMS, in order to diagnose premenstrual syndrome, we want our patients to keep a chart for a couple of months and document the length of bleeding so that we know if they truly are having PMS. We don't understand it. It's a biological trigger. Some of the risk factors are age, family history. We have a variety of symptoms. Usually it's pain, bleeding, breast tenderness, depression, headaches, mood swings, just all kinds of irritability going on there. It's very difficult to manage it because different women react in different ways. Again, the diet and exercise is coming up, and that's basically all they do with PMS. Now, some PMS, again, is being treated with some antidepressants, and so they've been able, like maybe Paxil or Prozac, and it's been proven to be helpful in there. The premenstrual dysphoric syndrome, it's more severe than PMS. It, kind of puts you to bed. You can't get out of bed. You can't climb. You can't even face the day. They think that it's probably a hormonal based reaction. And usually you see that a lot of depressive disorders when you're having thoughts of suicide, panic attacks, just all kinds of emotional feelings that you have. So these people are also treated with some of your antidepressants. Menopause, of course. Oh, we're not ready for menopause. We need to do the toxic shock syndrome. We've talked about toxic shock syndrome before. Toxic shock syndrome is where we want to remove the cause that's causing the toxic shock syndrome, which basically most of it has been insertion of a tampon that's been left in too long and developed some bacteria that causes the toxic shock syndrome. The first thing you want to do, of course, is remove the tampon, get rid of the cause, and then do the treatment with antibiotics. Be sure to teach your patients to wash their hands before and after they have inserted their tampon. Now we're ready to go into menopause. Menopause, of course, affects every one of us women who have either had our uterus removed or no longer ovulating. Menopause is defined as 1 year spent without a period. So you have to go a whole year before you're graduated into menopause. You are premenopausal before then, which means you can still suffer all those horrible hot flashes and things, but you're not considered menopausal. Usually in menopause, we are going to see the biggest complaints that most women have is vaginal dryness, and that's usually caused by your estrogen deficiency. You no longer have estrogen. And your hot flashes. Hot flashes are one of many, many women's major complaints. They're caused by the lack of estrogen that allows the other hormones to take over control, and kind of it's just like a vasoconstriction reaction. So when we finally get to that menopausal stage, we can use estrogen replacement treatment especially if it's an early hysterectomy and it's early menopause. We definitely want to keep these women treated with estrogen because the symptoms are very severe. Not only are they severe, they may need an antidepressant because they've lost their ability to have children. When we use estrogen replacement therapy, we need to be sure we're teaching our patients how to do self-breast exams and make sure they do the monthly, because there is an increased risk in using estrogen replacement therapy. There has been controversy in all these years I've been teaching it. 1 year it's great, 1 year it's bad, 1 year it's great, 1 year it's bad. Now it is, well, it's up to the doctor if the benefits outweigh the risk. If you're having such horrible symptoms, the risk is so small, you probably want to do the estrogen. So it just depends basically really on what your doctor believes that you should be doing about that. Then we have reproductive disorders. You have infertility, abortion, all these good things that I need to talk about. Excuse me. Infertility, of course, is usually diagnosed if they've gone more than a year without being able to have a pregnancy after trying for this year, trying for a year. Male and female factors are involved with infertility. You don't, can't blame one over the other, and you really should try to keep them from trying to blame each other. You've got a couple of boxes on page 1273 that tells you about male fertility, risk factors, and risk factors for female fertility. If y'all want to look at that, usually your most ones that are female related are related to the ovulation, and males are usually related to sperm production. So usually they try to figure out what the cause is and then try to direct their treatment toward that particular cause. So they can do in vitro fertilization, they can do intrauterine insemination, they can do quite a few things anymore for infertility things. There is ethical issues. You can read that ethical box about that if you would like. We actually had a physician refuse to do infertility treatment to a couple because they were both deaf. They could see and they could write and they could communicate, that they were both deaf, and he didn't want to bring another deaf person into the world. I think that was unethical. You can think about that and see what you think about it. Abortion, of course, we talk about it being abortion versus miscarriage. So it's either an induced or it's spontaneous abortion is how we usually refer to it. It's before 20 weeks gestation. The spontaneous ones are, but your induced ones can be almost up to pregnancy. So there's a negative. Again, we talked about how it's negative to use the word abortion around someone who had a fetal loss. So you really want to make sure that you're not. On chart 4112, it gives you all the classifications of different types of abortion. You have your incomplete, complete, threatened, inevitable, missed. There's just several different categories for that. You want to send your products of conception and whatever else comes out down the lab to confirm what all came out. You normally can't tell if it's really early on what goes on, what really actually came out. So inducement of abortion is another ethical dilemma that goes on, and so we have a lot of issues that way. Some of the diagnostic tests for doing all these reproductive disorders, there is a bunch of those listed on page 1276, and so there's a lot of that in there. We've already talked a little bit about a hysterectomy. It can either be a vaginal hysterectomy or an abdominal hysterectomy, depending on why you're having the hysterectomy, as to if you're going to have any kind of issue with the fact that you're not going to have babies anymore. And hysterectomies have become fairly commonplace, especially the vaginal ones, and they usually go home seems like next day. Then your intimate partner violence. This is something you can't get a handle on no matter what. Whether you're the victim of a date rape, or whether it is your significant other. It's very hard to get a client or a patient or a victim, whatever you want to call her, to come in, because they feel more like the perpetrator than they do the victim. It's like they were practically asking for it. So when we help with a sexual assault, first of all, we need to reassure our patient that she's worried about information getting out. We need to make sure that we make sure that our patient understands that we are under a HIPAA code. We do not discuss anything. We don't release any information unless we have a signed consent from her. Even the police department cannot get any information from her medical records without her consent. So even if she goes through the whole rape kit and decides that she don't want to give any information out to the police, she doesn't have to. Oh, I forgot to talk to you about the breasts that I wanted to talk to you about. I wanted to talk to you about the mammogram screening. It is a screening. It's not a preventive issue, and we need to make sure our patients understand that just because you have a mammogram done does not mean that you are preventing cancer. Be sure that you know when you're doing a physical assessment that you remember the inflammatory ridge is a natural part of your assessment. Most lumps that you find in the breast are 90% benign. Mastectomies, you want to consider body image, grief. Don't take blood pressures or draw blood in the side that they're done, unless, of course, you have a double. And then with your endometrial cancer, which we did not address, the treatment for that is intercavity radiation. They should have a private room. Be sure that if it dislodges, that you use proper techniques to be able to pick up the radioactive isotope and dispose of it properly, as of in a lead box.